Thank you everyone for joining us today. My name is Kelly Rudd. I'm the National Sales and Marketing Manager for Laerdal, Australia and New Zealand, and I'm the moderator for today's webinar. During this session, if you have any questions, please send them through the Q&A function, and we will have 15 minutes at the end of the webinar to go through these and have Nancy help us answer them. All attendees will be muted to minimise the background noise, and this webinar today will be recorded, and you will get an email with a link to the recording within the next few days. We are privileged today to have Nancy Sadka with us. And during this webinar, Nancy will be sharing her experience on a hospital-wide quality improvement in situ simulation project at Victoria's Northern Hospital. Now let's welcome our speaker, Nancy Sadka. Thank you, Nancy.
Thank you so much, Kelly. Much appreciated. I want to start by thanking Kelly and thanking Laerdal for this opportunity, and thanking you all for being part of this with me. And it's a great opportunity and privilege for me to be able to present this talk. I also want to apologize in advance if there's any technological problems, because I'm not very tech savvy. So bear with me if anything happens. So I wanted to start firstly with our key message, or my key message, which is that simulation for quality improvement can significantly impact your health service and outcomes by improving hospital systems and changing hospital culture. This is something that if there's one thing you remember, it's that you can do this at your health service. So this is possible. It's not something magical. It does take a process, but it is possible. What I want to cover today as an overview of the talk is a summary of my simulation journey. And I wanted to share that so that we can see that it is possible for this to happen at any health service. I wanted to talk about how we developed a hospital quality in situ simulation team, how the project started, how we brought the team together, the executive support, how we implemented currently, the impact it's had on our hospital, which I think is quite dramatic. We will have a little segue into the challenge that COVID created for us, of course, which has been presented to the whole world, and also for the sustainability of such a project. So just to start, very briefly, I started in simulation as a participant. Like a lot of people, my initial exposure was as an emergency medicine trainee. And I remember my emotions when I first had to be or participate in simulation. And this is how I felt. I was nervous, I was uncertain, I was uncomfortable. I thought, oh my God, this is going to be embarrassing. And as I participated more and more and then grew to learn more about simulation, this was my learning point, was that comfort takes time. It takes time for people to be comfortable with simulation as a modality. And that's not just for learners in education settings and in sim centers, but also for in situ simulation. So that was a really good learning lesson for me, which then has translated to my approach of how we do our in situ simulation. I then was able to grow in simulation and learn more of it as a learner and an educator. I was fortunate enough to have a position of an education registrar at the Austin Hospital. And my mentors there were Dr. Victor Lee and Mrs. Robin Purcell, who really helped me grow and learn about simulation. And with the team at the Austin, we were able to plan and run simulation for education sessions. And we implemented something which is called simulation gamification, or live, die, repeat scenarios, which again, I was fortunate enough to present as a workshop at the Sun Conference last year, and also at the Victorian Faculty Conference. And this in itself helped me grow in simulation, to understand that simulation is a tool that allows us to do lots of things and that we can learn in different ways. So it really helped me to expand my understanding of how to use simulation. I then was fortunate enough to attend a presentation by Dr. Victoria Brazel. Now, for those who don't know who Dr. Victoria Brazel is, she is a leader in simulation in Australia and beyond in the world. She leads a simulation team at the Gold Coast Hospital and Bond University, where they do simulation for quality improvement as part of what they do. And this is directly taken from a paper that she has written describing translational simulation. So this was a very interesting concept for me to come across, because this is what spurred on my passion to say, actually, we can use simulation in all these different ways, and it can help our service performance, it can diagnose problems, it can help us intervene and translate things into practice, and really can leave us with a better health service with better outcomes, both for our staff and for our patients. And it was very inspirational to listen to the presentation that she made about what they do at the Gold Coast Hospital. And I remember thinking at the time that I wish I could do this. I wish I could be part of this. I wish I could move to the Gold Coast. In fact, that was my first thought, and that wasn't just for the beautiful weather, but also to be part of this team. But then my second thought was that that wasn't an option for me. And so what could I do in my hospital? And so that became the driving force for me to say, how can I try to take some of this great inspiration and this vision, and how can I try to implement it in my hospital? And I move on to where I am now. I started as a consultant at the Northern Hospital in emergency 2 years ago now. And I just want to describe the setting of the Northern Hospital, because I think that does impact how people see the potential of a space. So the Northern Hospital is a major provider of acute services in Melbourne's north. It is a very busy hospital, but it is not a very big hospital. So the hospital sees about 107,000 patients in ED a year. Approximately 94,000 are admitted throughout the year between ED and other admissions. It is a maternity hospital as well, with approximately 4,000 babies delivered every year. The hospital itself only has 330 beds across 4 sites. So relative to the demand, this hospital is not big enough to service our region, and we know that we have a growing population, so we're looking at tremendous growth in the northern suburbs in Melbourne for the next 5 years. And so this is actually the setting for a hospital that you would think on face value is under-resourced for its service provision. And given that, a lot of times we think that because it's a hospital that already doesn't have a lot of facilities and resources and money, we can't possibly do an intervention like having a quality program. So that is, I just want to encourage everyone who is in a hospital that isn't the biggest hospital with all the resources, that it is possible to do this. So how did we start? So this all started with last year in April. We do have a simulation center, and the manager of the simulation center decided to have a simulation community meeting to try to boost what we do with simulation. And that meeting was an invite to almost everyone in the hospital. If you're interested in simulation, try to come to this meeting. That was in April of last year. During that meeting, I had spoken to some of the people I knew were going, and we put a proposal saying that what we want to do is have a hospital quality improvement simulation project. And that what we need is a team. And that team we envisioned would have 6 to 7 team members potentially. So if you have a team, that means it's not one person trying to do things. And we can work together from a multidisciplinary team and try to run some simulation for this reason, for quality improvement. And I want to say from the beginning right now that everything that has been achieved in this project has been because of having a great team. So I can't emphasize enough that this has not been a single person project. This has been a team effort the whole way through. But what was interesting in that meeting is that one of our senior ICU consultants said to me, "We cannot do this without having executive support." And I completely agree with that statement. And so the next thing was to try to garner some executive support. And I do think this is essential, because if you're trying to introduce something across the hospital, trying to do an intervention which is going to take up staff time, staff space, because we want to do in-situ simulation to improve quality, and to identify system problems, we have to do it in the clinical space. So we want to take up time, we want to take up space. We do need support. And that support was very readily available. I want to thank my ED director, Dr. Megan Robb, because she has been tremendously supportive of myself and of this project. And also Dr. Bill Shearer, who is the Executive Director of Transformation and Quality and Safety of the hospital, who was willing to trust us enough as a team to start doing this last year. With that, we had the support of the HRO team. Now, We have a hospital HRO team whose goal is to help clinicians work in groups in order to improve systems and quality. And so the HRO team became very invested to help us as a simulation team to be able to accomplish what we wanted to do. The next thing was, how was it going to work? So we made a project plan, and initially the plan was to run one hospital multidisciplinary in situ simulation every second month, so starting very gently, and then increase that to monthly in this year of 2020. We were going to target hospital quality improvement goals and areas of risk, and having the executive support of the quality and safety team of the hospital really helped us to know where to start, and where we can start our effort. This was going to be across the whole hospital, and we aim to identify opportunities for system and human factor improvement. We were going to do SIM reports, which were going to be shared with everybody who is relevant for the changes that are needed. And we needed a quality cycle, which was to repeat the simulation every 6 to 8 months and look at whether the recommendations we have made have actually been implemented, or what else needs to happen. And I'll just say that this is actually a photo of one of our simulations. This is the first simulation we did when we started this project, prior to physical distancing, sorry. So the process, and I just want to talk a bit about this because this is a bit different than how I planned simulation prior to doing this project. So we identified the area that we wanted to focus on. It was really important to talk to the people in this area. So if this was going to be a code trauma simulation, it was important to talk to the surgical team. It was important to talk to the ED team. It was important to talk to the trauma team, and to find out what are the things that people already think are a problem or not a problem, and what are the questions, so that we can have the right goals from the simulation. So are we trying to diagnose a problem? Are we trying to find solutions to a problem? Are we trying to test the system? And so that was an important part of planning and writing the simulation. And then I just want to talk also about safety in these scenarios. So obviously we are running in situ simulation in the clinical space in a real-time setting. And so it is actually very hard to create a safe simulation environment in that setting. In fact, almost impossible, because when I call code blue hospital-wide and I get a response, I'm not exactly sure of every person who is coming to that code blue. So one of the ways I tried to build in we tried to build in some safety into the setting was to actually share the scenarios with all the participating staff ahead of time. Because again, we're not trying to test the staff or their clinical judgment or their clinical decision-making. We are trying to test the system, and we are trying to find areas that we need to improve in our systems and how we interact as teams, and not, trying to figure out if the patient has a broken femur or a broken tibia. So it was important to create that safety. And this again came back to me remembering as a learner how hard it was initially to be a participant in simulation, and how that was scary. And I kept thinking, how can I create that safety for staff who may have not participated in simulation? The next step was to liaise with all the teams again involved, and then to pre-brief everyone about the scenario. And this again, I highlighted because we did this quite differently than I'm used to in pre-briefing, because I was used to having this moment where we all meet before the scenario, pre-brief, and then we run the scenario. But we found that was difficult in our clinical settings. And so the pre-brief was this liaising with the teams over the 48 hours before, where we would again go and talk to the nursing staff on the ward, meet with them a few hours before the time of the simulation, accommodate the simulation to the time that worked for them the best, and make sure that everybody understands what we're planning to do and what are the goals from this. And then when it came to the moment of the simulation, we would arrive with the mannequin, place the mannequin, and run the sim. So the pre-brief was removed slightly in time from the actual scenario, but still vital in order to be able to actually run the simulation successfully. Then there's the process of running the simulation, where we would just run it for a 20-25 minute time period, or sometimes a bit longer if needed. The debrief was very important as well, and that was organized. We'd have multiple debriefers, and each one of us was looking at different aspects of what was happening, whether it was a human factors aspect or whether it was the actual systems or the timings. And that was really important, because having a team of debriefers who have planned how they're going to observe, but also planned how they're going to debrief the scenario. And this is, again, another photo of us doing one of our simulations in the cath lab. So we would then produce a simulation report identifying the areas of improvement. This report would be shared with all the participants, also with the In Situ team, and then also go to all the heads of units in the hospital, including all the standards committees that needed to be involved based on what the scenario was. And after that, we also produced another document, which is a PACE document, which is something for our quality team. For those who don't know, a PACE document is a performance analysis, communication, and escalation document, which had specific recommendations with a plan, again, to follow up with re-simulation in 6 to 8 months to see how we have, if we have met those recommendations, and if not, what are the barriers. So this is just a summary of the simulations that we have run to date. So we started in May of last year after that meeting in April and getting support. We ran our code trauma and ED, followed that 2 months later with a cath lab code blue. And then in October, we went to the surgical wards, and we ran in December in eclampsia. So we were doing well with our 2 monthly sims. We arrived at January, and we're back to our code trauma at the 6 month mark in order to re-sim. And we planned to escalate to monthly sims, and we ran one in February. And then to make the understatement of the year, of course, things did not go as planned after February. And we ended up having this, segue into COVID-19 preparation. And I'm going to talk about that because I think this project really facilitated the impact we were able to have on the hospital for COVID-19. And as of June, we have now gone back to doing 2 other sims in June, where we've run a medical met call on the medical ward, as well as another code trauma simulation in ED. And I want to share some of the outcomes we've had, because I think I've learned that it is very important to actually keep track of your outcomes. If you're going to say that we are making a difference, that what we are doing is valuable, then we need to track what we are doing and record that. And again, I want to thank our HRO team tremendously from the Northern Hospital, because they have provided that administrative support to help us to do this. So they set up a spreadsheet of all the recommendations from every simulation with the follow-up of the outcomes. And to date, we have made approximately 32 separate recommendations for system or policy changes. And 24 of those recommendations have been completed so far. And we continue to retest the system when we re-simulate and see that these recommendations remain in effect. So we're following up on the things that we are recommending, and that is quite important. Just some examples of specific changes. So in these recommendations, we have been able to make changes to our deteriorating patient and code blue policy, to our trauma policy, to our STEMI policy, to our METCALL communication system on the ward, and we've started some multidisciplinary METCALL team training, which wasn't happening in the hospital, which definitely was one of the areas that we identified would really help our outcomes. And so these are just some of the recommendations that we have made and the changes that have ended up in policy changes. And the other thing we were looking at is decreased risk incidents. So we were targeting areas where there had been high risk incidents. And this particular graph just shows in this particular space that we did a sim in August. And after August, you can see that we had a tremendous drop in our incidents that we were receiving, from whether that be, risk commands from staff, or whether that actually be patient incident. So we were able to show that actually when we do a simulation, we improve our processes together, we can make a difference on our outcomes. And we have also had a lot of feedback from staff regarding improved processes and collaboration between teams, specifically in code situations when we've done simulation. And what's interesting, and I want to again give complete credit to Dr. Victoria Brazel for telling us this, that when you do this type of simulation, there are the measurable outcomes that I've just listed: changes to policy, decreased risk events in an area, and these are the measurable outcomes that we tend to have to report on, but they probably make up 20% of the actual impact you're having. This over here, the hospital culture change that comes from running a project like this, has been dramatic in our hospital. I can't call it as anything less than that. So over the course of this time period, simulation has become part of everyday business. And that is for every staff member. And that goes all the way from our switchboard to our cleaners and our radiographers. Everybody understands that we are going to run simulation. It's going to be part of everyday business and why we're doing it. And that's been a huge change. There's been a huge change in our collaboration across our specialties, across our multidisciplinary collaboration, because we work together, we sim together, we identify problems at the front line together, and then the actual workers who are doing the work every day have a voice to influence policy and to influence how we do things. We've created teams. The team building across specialties has been excellent. Our stakeholders feel that they can influence what happens. And so when we have delays to why we can't get to CT fast enough, and we listen to our PSAs and they say, well, this is a problem, and then we can do something that changes how we do things, and so they are heard. And also we found that in our simulations, we have identified areas of system resilience. I just want to explain that, because in every hospital, there can't be policies for everything. And there are workarounds that our staff do every day to keep our hospital safe. In every one of our hospitals, our nursing staff, our cleaners, our doctors, everybody is trying to keep our patients safe and to produce good quality care. And there are workarounds that develop that nobody knows about. And when we run a simulation, we'd say, oh, why did you do this? And they'd say, oh, we always do this because that's the only way to get this done. And that was a very interesting thing to identify, and then to be able to document, to say that actually this workaround is a good workaround that our staff do, and they do it all the time, and maybe it should be part of our policy. And therefore it doesn't get lost when these staff members are no longer there. It actually becomes part of the organizational memory. So that's been a really interesting find. Again, very difficult to quantify as a measurable outcome, but a true long-standing outcome for the organization. And the building of trust. We talk about this across teams, but teams that practice together, improve things together, build that trust that we're all working for the same goal. And this is the other outcome that has come out of this project. So it has been a very interesting thing, and I did hear it from Dr. Brazel. She has been a real mentor to us through this journey and has helped us a lot to get to where we have. And she did say, you will find that the measurable outcomes are about 20% of the benefit, and the immeasurable outcomes that change how the hospital operates, feels, how we work together, that is a huge benefit, but it's not quantifiable. So what about the project outcomes itself, or what have we achieved as a project in the last year? So we started off wanting maybe 6 to 7 team members, and we now have 26. We have sim leads within multiple specialties, so people who have taken on, a different portfolio, and they are doing the surgical leading, the ICU, the pediatric, and that's just brilliant. We have support from our hospital simulation center. We've had run a workshop with Dr. Victoria Brazel. She came down in November to the Northern Hospital, and it was brilliant to listen to her talk to the whole team about how we can accomplish more with this simulation. And also we had 6 other health services in Victoria that came and attended that workshop. We have run a faculty development course for simulation and debriefing, which was assisted by the Austin Hospital for us to be able to run here. And we now have some engagement again from our university, from Melbourne University, with medical student simulation assistant positions, volunteer positions, to help. This project has been able to do more in this 12 months than I had anticipated. But again, I want to emphasize that this was because we have a team and because we work together as a team. I also want to say that this team is not yet resourced. So we are all working together, but we are not actually in paid positions to be doing this work. And that's another thing we'll talk about as we go. But because it has been a team effort, the work is lighter. The more people you have, the lighter the workload is to achieve what we are trying to achieve. And then, of course, we had this, unexpected pandemic that we were all faced with. And it has been a tremendous challenge to all health services across the world. And suddenly there was an urgent need to test our systems, to identify gaps, to prepare our staff, and to train our staff. And we were called upon as the in situ simulation team that had been already established in the hospital by then, and asked to help with hospital preparedness. And so we had, like I said, planned to be running monthly in situ simulations across the hospital. And so over the 6-week period between the middle of March and the end of April, we ran 13 multidisciplinary in situ simulations, which involved multiple departments, and everyone literally in the hospital was involved, to identify areas of improvement and gaps for training needs. We subsequently, after identifying that, started running multiple daily simulations across the hospital in the areas where recommendations we found we had gaps. And we also were running daily multidisciplinary COVID algorithm airway training for our critical care teams who work together as an airway team. So this effort in response to this pandemic was an actual really big event for us. And I truly believe that having our in situ simulation team already established really helped us to be able to escalate and have a response to this. And I heard this very interesting statement that it is easier to pivot than to design from scratch. And I think because we already had the team, we were able to just pivot our focus completely to COVID-19 preparation. So of those 13 sims, this is just a list of things that we did. We ran front door simulation at the ED. We ran intubations in negative pressure settings. We had a really large sim I want to mention on the 19th of March, where we had a patient journey, the patient being intubated and then moving to our recovery area and moving to our ICU. And that simulation itself involved everyone, our PSAs, our cleaners, our infection control, and all our critical care teams. And we had 20 members of the team, essentially, to help to organize, run, debrief, and then try to improve our processes. And so tremendous amounts of effort, but huge impact on the hospital. We also ran multiple simulations in theater, in cath lab, at our other health services where they might see patients who walk in who are suspected COVID, pediatrics, neonatal, COVID cohorting in wards. Needed to help train the wards to be able to deal with a code situation, code strokes, and what happens when the CT scanner is getting cleaned, and pediatrics again with a patient needing to go urgently to theater. So we were actually able to pivot in our team and be able to shift our mindset to how do we now help our hospital prepare for this pandemic. I also want to mention that in this preparation, this also changed some of our processes, because we were used to having multiple debriefers and lots of people involved, and yet we now had to physically distance. We had to decrease the number of people involved. We had to think about how much PPE we use and which PPE we use. How do we recycle that so that we are not wasting? And we even introduced, with getting people's permission, filming of some of our simulations in order to decrease the number of observers. And that was something, again, that was new to our hospital. We did learn a lot of lessons from our simulation for COVID-19, and this is an infographic we made for the hospital for learning. And I'll just share briefly that PPE takes time and it delays everything, but it is vitally important. And we learned that if you don't practice, then the likelihood that we do this badly is very high. So in every one of our simulations, we tried to invite someone from infection control to attend and essentially watch how we on and off so that we can get that right and identify who needs more training. We learned that you need two teams, a patient team that's the contaminate team and a support team, it's a clean team. And that was something that we needed to practice because we weren't definitely not used to doing it, neither in our emergency department nor on our wards. Communication is difficult, and we had to work out how we were going to communicate across our spaces, across closed doors, across negative pressure. And again, the practice was essential to help us to feel that we have resolved these issues, or that at least we know where to start in getting better at it. Transport was a big issue. We really needed the involvement of our PSAs and cleaners to figure out how we're going to move patients safely from point A to point B when they are suspected of COVID, and how do we make sure that we're following infection control. And we had to change our processes in the hospital for transport. Senior review and early decision making is vital in these situations, both for decisions of treatment and management, but also for patient disposition. And again, doing the simulations involved all the teams in the hospital and all the specialties, and allowed us to see that it's really important that we have senior review, and early senior review. And then we recognized very quickly that we are asking our staff to perform unfamiliar roles while facing extraordinary stressors. So they're facing a pandemic, we're facing personal pressures, and we're working in PPE, which is difficult. And so it is essential that we do identify the gaps and that we provide the training. And simulation was really able to help identify the gaps and provide the training. So as an impact of our Insight to Simulation project, this was something I did put together for our actual heads of units of the hospital to say, quality improvement is everyone's business. We need to have team building and translation into practice. And simulation has helped us have a culture change in the hospital, establish our team, and then provided this platform to establish, test, and improve our systems for COVID-19. And I really think that if that we would have struggled more to prepare for this pandemic had we not had our project going before. I wanted to share this because we do have a vision for simulation, and like with anything, it's important that we fight for sustainability. So this is the vision we have for our team, that we would in the future have a medical simulation lead, possibly that we would have multiple simulation leads and across the different areas, and that we would collaborate with other health services and be able to resource this endeavor. At the moment, we are still in that stage of, fighting for resources, I guess. But again, because we have a team and because we have a lot of people who are invested, and because we have the executive support, it has not felt overwhelming to this stage. And I just want to talk about sustainability, because I think whenever anyone thinks about, can we do this at our hospital, we're always thinking about how can we sustain this? It's going to be too hard. We don't have the resources, we don't have the time. But if we get enough support, if we can get the support of each other as a team, if we can get executive support, we can find the time, we can find the resources. But then what we have to do is then fight for the sustainability and make our contribution valuable. So we have to demonstrate that we are, quality and safety is a very good way to make our contribution valuable. Research is also a good way. Collaborating with other departments and other services to try to make our work a bit easier by not reinventing the wheel. So I'm really big on us collaborating as hospitals, and I am personally, and our team are happy to share everything we do with other hospitals, because we think we should not be working in silos. We should be working together as health services. We should be helping each other improve. And we, as the Northern Hospital, could not have done this with the SIM team without the support and the collaboration we've received from Dr. Victoria Brazel and the Gold Coast Hospital. So this collaboration is vital because it really helps you to not have to start everything from scratch. We would love to source some funding. We are always looking for that, whether it be internal, whether it be philanthropic, whether it be grant funding. It would always be nice to be able to resource people for what they do. And that means that it will be sustainable. And that is definitely what we are working for as a team. But we do support each other through this process. And this is why we've been able to achieve what we have achieved to date. And so I want to go back to my key message, because I really think, again, that a lot of us know that we would like to do this, or a lot of us think that this is a possibility. And now you know from listening that this is a possibility, but we get discouraged by if we work in a smaller hospital, we don't have the resources, we don't think we'll be able to sustain it. But it is so vital. We can do this. We can improve our health service. We can improve our systems. We can change the culture in our hospitals so that it's collaborative, so that we trust each other, so that we, as a team, allow everyone to contribute, and this becomes everyone's daily business. And we can build the system resilience. We can identify the areas where our staff do really well, but nobody has documented why we do really well. Sometimes it's about looking at why bad things haven't happened, not just why bad things have happened. So we need to focus, if we can actually focus our health system on that and really improve our outcomes, both, again, our staff outcomes and our patient outcomes. And I personally believe this is possible, and our team here believes it's possible, because a small team committed to a cause that is bigger than themselves can achieve absolutely anything. And this is a quote from Simon Sinek, who is one of the people who gives talks on leadership and how we can work together. And I'm hoping that through sharing this with everybody, that this will motivate people, firstly, to see the possibilities of simulation, what can be done. Simulation is a tool, it can achieve lots of things, but also that this can be achievable, and it does have some key steps, but it is achievable. And also to open the door to say that we need to collaborate across our health services. Laerdal provides us with this simulation format where we can share things about simulation, and we need to use these platforms to work together as hospitals, again, so that the work feels lighter and so that we can share our resources and our expertise. So thank you very much for this opportunity today. It's been a great privilege.
Thank you very much, Nancy, for a wonderful presentation. Nancy, while you're still on the line, we have a few questions for you. So the first question, if you can hear me okay, is from Amanda Barrick, who attended today. Have you engaged former patients in the process to address areas they have identified?
So that's a great point, Amanda, and engaging the consumer is really, really important. So one of the things we have done is look at patient complaints in some of the areas where we have run our simulation, but we have yet to actually engage patients in the process. So we have looked at some areas where there have been complaints, and then when we've run a simulation, if there was any feedback we could give through our patient complaint team, we have done so. But as of yet, we have not actually brought the patients into the process. It would be fantastic to be able to get to that point where the patients themselves can actually come and contribute to the process. I also want to say that we have used simulation actors. So we have used people who are consumers, not necessarily patients at the time, but who have come in and been the patient or been the family member in the simulation to get that perspective and that viewpoint. So trying to use simulated patients in our sims helps us a little bit to get that perspective, but it'd be fantastic to be able to get the actual patients to be involved in the process.
Thank you very much, Nancy. I have a question also from Matt Jackson, who says, "Hi, Nancy. I was wondering how you collected the information from your participants, for example, questionnaires and face-to-face."
So what we did is we spoke to all the participants in the pre-brief. And so this was just a labor of time. So going to the wards, talking to the ward staff, talking to the surgical team, and so this does take time, this preparation for the actual simulation to decide what the goals of the sim are and to write the simulation does take that investment of time with the different groups. And then after the simulation, what we do is we take down the names. We have an attendance sheet of everyone who's attended, and they get an email which has the report, and they're encouraged to feed back to the team about any extra things they've thought of or anything else they want to contribute. But the pre-brief part where we engage the participants before the simulation, that does take time. And that was going to the ward, talking day 1, then day 3, then sometimes day 5. So usually spending about a week or more planning in your head how you're going to engage the participants pre the simulation. And again, reassure them of the safety. That was so important, the safety of participation, the safety that this is actually not putting them, this is not a test for them, this is a test of the system.
That's fantastic. Thank you, Nancy. Another question. At that first Project Sim meeting, did you ask people to come with ideas of what they wanted to achieve, or was it just to see mainly who was interested in sim training and who wanted to go down this pathway that you wanted to go down?
So, very good question. In my head, I had the proposal of having an in situ simulation team for quality improvement. And that's what I went to the team with. And at that time, we had a good, I think, 30 people attending that meeting. And we opened that up to discussion as to what that would mean and what, as a team, we would want to achieve. So the idea probably came from my inspiration from the Gold Coast team, and the idea that we focus on systems improvement and human factors improvement with our simulation. But a lot of the actual details of how we would go about that process, garnering the executive support, etc., actually came from the team together when we talked about it. And in that meeting, the initial 6-7 people put their hand up to be part of the team just in that initial meeting. And then as we developed this, more people said, I want to be involved, I want to be involved. And it grew to being a 26-person team now, and probably more because we've got more people now as people hear of it and are interested, say, I would like to be involved, I would like to be involved. So.
Oh, thank you, Nancy. And this probably leads really well into Joy Davis's question, because did you specifically target people potentially to join the in situ team? Or was it more about a general expression of interest? Or did you have your eye on a few people potentially?
No, of course I did have my eye on a few people, but it wasn't that we already had a few people who I knew were very passionate about simulation when I came to the Northern Hospital. So a colleague of mine, Cynthia Lim, has tried to champion simulation across the organization, and she has done a great job doing that in the past. We have another colleague, Keith Maracone, who is a trauma simulation lead elsewhere. So I knew we had a good base of a team of people who were interested in simulation and who did have the skills for writing simulations and debriefing, because that's also very important. You need to have those skills before we can debrief in that setting. And so having that base team who I knew would be interested if we had the opportunity allowed me to, I actually had spoken to a few people before that meeting and said, how about this proposal? Are you happy that we propose this? So it was something where, yes, it was a combination of people who I knew and I knew I could count on for support. And then other people who I did not anticipate meeting in that meeting and have become a very big contribution to the team.
Oh, thank you, Nancy. You can't leave the hot seat quite yet because there's a couple more. Phyllis Fu has asked you, how do you get buy-in in the early stages without any evidence? That would be practice changing.
Yes, so this is actually this is again difficult. So initially, when I made that proposal, one of the members of the HRO team, Brooke, was in that meeting, and I never met her. She came and said to me, "This sounds very interesting. How can we support you?" And so we set up a meeting to talk about how we could do it. And it was at that meeting that, incidentally, the Director of Quality and Safety was close by. And so we just took the opportunity to get into the door and have that conversation. So initially, the support for this project came from the few people who were the core people I knew were interested from that initial team, and also from my own department, so from the ED and from my director, who again I had spoken to before trying to do this. And once we had that support, I needed to get that next level support. And then once we had the quality and safety director go to try this, it was about doing the first sim, showing that we were going to hold true to what we said, that we were going to take this much time. This is what we needed, that we were going to produce a report. And then as we demonstrated that what we were trying to do, we were going to do, the trust in the organization and even from the executive has grown, I think, to the point where when we got to our COVID pandemic response, they trusted us to actually lead this work.
Thank you, Nancy. And we have one final question. Do you have midwifery or nursing student simulation assistance?
That's very interesting. We would love to is the answer, but we don't yet. So we have done quite a few simulations in birth suite and in theatre and with our maternity team. We've got a very, very engaged head of unit of our obstetrics unit who's happy to be involved in simulation, is actually part of our simulation team. So we would love to head in the direction where we have more student involvement. They definitely get involved on the simulation, in the simulation on the day if they're there, but to be actually part of the planning and running of sim. And that is the vision, that we actually have our heads of units support this work in each of their areas. And that would mean that everybody's responsible, everybody's doing this, we're all working together. And it's a lot less work. It's not the sim team going into a space and telling people what to do, not at all. We go into the spaces invited by the teams that are already there to help them to improve the systems. And that is our role.
Thank you, Nancy. Just before that, though, one final question from Joy Davis. Can you please outline what information you give in situ scenario participants for their safety? Do they receive the written scenario template or a verbal synopsis of the?
They receive the scenario as it is written, the template with everything that's going to happen. And I do go and give them, not immediately before, but removed in time in that pre-brief, I do go and tell them again exactly what is clinically going to happen in the scenario. So I'll give you a quick example. A trauma simulation, I took the consultant who was going to be involved, the nursing staff. I said, this patient is coming in. These are his injuries. This is what his hemodynamics are going to be like. And we want to take him to the CT scanner and try to do that within 30 minutes. We want to do a primary survey, a secondary survey, and be able to go to CT. So they have all the information of what we even would like to achieve clinically. Now let's see if the system supports that decision making. So just let's test the system. Let me see if can we actually do what we want to theoretically do clinically. So it's not, they don't have to think about the clinical decision making. They just have to run through that scenario so that we can actually look at the system.
Once again, Nancy, we'd really like to thank you on behalf of Laerdal and also thank the attendees for joining our live webinar today. We will send out an email with the link to this recording over the next few days. We have a third webinar running on the 16th of July, and further information will be on our website and via email within the next couple of days. There will be a brief survey at the end of this webinar this afternoon, and we hope to see you all again very soon. And many thanks again, Nancy Sadka, for joining us today.
Thank you so much for the opportunity. Much appreciated.